Before you sign that consent form, I need you to hear this. Agreeing to surgery in the moment your doctor recommends it is the single most reversible mistake you can make. And if you say no without asking the right questions, it can also be the most dangerous one. Write that down, because today I'm going to show you exactly where that line sits and how to know which side of it you're standing on. Almost nobody tells patients over 60 this in the exam room. The operation itself is rarely the danger anymore. Anesthesia is safer than it's ever been. Surgical technique has improved for decades. The real danger is what happens after SATs, in the weeks where your body has to rebuild itself from the inside out, and where a person who walked into the hospital independent can walk out of it changed for good. My name is Dr. William Parker, and for 18 years I've been breaking down the health decisions that get glossed over in a 10-minute consultation, the ones families only understand fully after it's too late to ask a different question. Today I'm walking you through 5 surgeries where the gap between what you're told and what the evidence shows is widest, and where saying yes too quickly can cost you far more than it saves. Surgery 3 is the one almost every family regrets rushing into. And Surgery 5I, the final one, is the operation where you have the least time to think and the most reason to have already decided your answer before anyone ever asks you. If you only watch one section today, stay for that one. If this is your first time here, subscribe. This channel exists to give you the conversation your doctor doesn't have time for. Let's get into it. Before we get to the 5 surgeries, you need one idea to carry through the rest of this video. I call it the consent gap, the space between what a consent form legally covers and what you actually understand about your own risk. A consent form tells you the surgery is happening, what it's called, and what could go wrong on the table. What it rarely tells you are the 3 things that actually determine how the next 6 months of your life go. 1, your reserve, not your diagnosis, predicts your recovery. 2 patients can have the identical scan and the identical diagnosis and still walk into completely different outcomes because one has the physical reserve to absorb the stress of surgery and the other doesn't. Reserve isn't about age on paper. It's about muscle mass, nutrition, how well managed your existing conditions are, and how much cardiovascular capacity you're walking in with. 2 people with the same chart can have 2 entirely different bodies underneath it. 2, recovery is a negotiation your body has with itself. After a major operation, your body has to decide where to spend a limited amount of energy, healing the wound, fighting off infection, regulating inflammation, or protecting your brain from the stress of anesthesia. When reserve is low, something has to lose that negotiation, and often it's the thing nobody warned you about beforehand: memory, mobility, the ability to live independently. 3, the routine describes the procedure, not you. A surgery can be routine for a surgeon who performs it 100 times a year and still be the single most significant physical event of your decade. Those are 2 very different claims, and in a rushed consultation, they get collapsed into one sentence far too often, usually the sentence that ends with "nothing to worry about." Keep the consent gap in mind as we go, because every surgery on today's list makes a lot more sense once you're looking at it through this lens instead of just the anatomical problem on the scan. Quick question before we go further. Has a doctor ever told you a procedure was minor or routine, and it didn't feel that way afterward for you or someone you love? Drop a comment below. I read every single one, and it genuinely shapes what I cover next. The 5 surgeries surgery. 1. Elective back surgery for non-specific pain. Back pain is one of the most common reasons people over 60 end up sitting across from a surgeon, and it's one of the most commonly overtreated conditions in all of medicine. An MRI showing disc degeneration or mild stenosis gets presented as the explanation for the pain, and surgery gets offered as the fix. Often within the same appointment, the scan results come back. Here's the problem with that sequence. Degenerative changes on a spine scan are extremely common in people over 55, including large numbers of people who have no back pain at all. If you scanned a room of 100 pain-free 65-year-olds, a striking number of those scans would show exactly the same abnormalities being used to justify someone else's operation. Seeing something on an image is not the same as finding the true source of the pain. Multiple reviews of surgical outcomes for nonspecific chronic back pain have found that structured physical therapy and progressive rehabilitation produce comparable long-term relief to surgery for a large share of patients without the risks of infection, hardware complications, or the disheartening outcome of pain that simply persists after the operation anyway. That doesn't mean surgery is never right. For true spinal instability, nerve compression causing measurable weakness, or specific structural findings, surgical decompression can be genuinely necessary and effective. The distinction that matters is whether your particular pain has been matched to your particular scan finding through careful clinical examination, or whether the scan alone became the entire justification. Has this diagnosis been correlated with my specific symptoms through a physical exam or mainly with my imaging? Have I completed a full supervised course of physical therapy first? What percentage of your patients with this exact profile get lasting relief from surgery versus rehabilitation? Surgery 2, gallbladder removal in asymptomatic or mildly symptomatic patients. Gallstones are found incidentally on a huge number of abdominal scans done for completely unrelated reasons, a scan ordered for kidney stones, an ultrasound for something else entirely. Once they're spotted, removal is frequently suggested, even for patients who have never experienced a true gallbladder attack. The evidence here is fairly consistent. Patients with silent gallstones, found by accident, causing no symptoms at all, carry a genuinely low annual risk of ever developing a problem from them. Surgery, meanwhile, introduces a real, if generally small, risk of bile duct injury, and that risk climbs with age and with the presence of other health conditions. For a healthy 40-year-old, that risk is minor and easily managed. For a 75-year-old already navigating heart disease or diabetes, an operation that wasn't strictly necessary carries a very different risk-to-benefit calculation, one that deserves to be spelled out plainly before a date gets put on the calendar. Ask this: are my gallstones actually the cause of my symptoms, or are they an incidental finding being blamed for something else? What happens if we simply monitor them over time? Is watchful waiting a reasonable and medically sound option for someone with my specific health profile? Surgery 3, major joint replacement with poorly controlled chronic conditions. Hip and knee replacements are among the most successful operations in modern medicine, genuinely transformative for the right patient at the right time, under the right conditions. This section isn't an argument against the surgery itself. It's an argument about timing, because timing is where the outcome is often quietly decided long before anyone enters the operating room. When blood sugar, heart function, or kidney function are poorly controlled going in, the risk of infection, delayed wound healing, and serious postoperative complications rises sharply, sometimes dramatically. Elective means there is time. Time to bring blood sugar down into a safer range, time to optimize heart medications with a cardiologist, time to improve nutrition and build muscle around the joint before it's ever touched by a scalpel. Skipping that window of preparation simply because a surgery date feels urgent or because the pain has become unbearable is one of the most common and most preventable regrets that families describe months later. There's also a psychological trap worth naming here. Chronic pain makes patients want the surgery scheduled as soon as humanly possible, which is completely understandable. But a short, deliberate delay spent optimizing the body isn't a step backward. In the data, it's one of the strongest predictors of a smooth recovery instead of a complicated one. Ask this: are my chronic conditions at their best managed baseline right now today? Is there real benefit to a short prehabilitation period, targeted physical therapy and nutrition optimization before we schedule this operation? What does my individual complication risk look like today compared to 8 or 12 weeks from now after focused preparation? Surgery 4, major cancer resection without a full geriatric assessment. The conversation gets more serious here, and the framing matters more than almost anywhere else on this list. A cancer diagnosis creates urgency, and that urgency is very often justified. Cancer doesn't wait politely for a patient to get in shape, but urgency should never be allowed to replace a full and honest picture of what a major operation will actually cost a specific patient physically and functionally. Major resections, removing part of a lung, a pancreas, a section of colon, or part of a liver, can be genuinely life-extending, sometimes life-saving in the right patient. But for older adults managing multiple health conditions simultaneously, the surgery itself is only half of the equation. The other half is whether the body can tolerate the recovery well enough to go on and receive the chemotherapy or additional treatment that, in many cancers, provides most of the actual long-term survival benefit. A patient who survives the operation itself but emerges too weakened to complete that follow-up treatment may, in the end, not receive the full benefit the surgery was meant to deliver in the first place. That's a devastating outcome, and it's one that a fuller assessment beforehand can often help predict and prevent. Ask this: has a full assessment of my functional status and overall health, not only the tumor itself, been genuinely part of this recommendation? Would a geriatric oncology evaluation meaningfully change the plan on the table? What does realistic recovery actually look like for someone my age with my specific health history, and how does that affect my real-world ability to complete the entire treatment plan, not just survive the first operation? Surgery. 5. Emergency surgery. You never prepared for this is the one that matters most of all, because it's the one you will never have time to research when it actually happens. Emergency abdominal and vascular surgeries, a ruptured aneurysm, a perforated bowel, a major obstruction that can't wait, happen without warning, without any time for optimization, and often without the patient able to speak clearly for themselves in the exact moment the decision has to be made. The outcomes for adults over 75 facing emergency surgery are measurably harder than the same operations performed electively, under controlled conditions, and the recovery afterward is where independence is most often quietly lost for good. None of this is a reason to refuse emergency surgery that is genuinely life-saving. When the alternative to surgery is death, surgery is the right answer, full stop, no hesitation. What it is a powerful reason for is preparation that happens long before any emergency ever arrives, because the two factors that most influence how someone comes through an emergency operation are the physical reserve they walked in with, and whether their wishes were ever clearly documented and openly discussed with the people who will be standing in that waiting room. Ask this of yourself today, quietly, not in a hospital corridor under fluorescent lights. Have I actually talked to my family about what level of intervention I would want in a genuine crisis? Do I have an advanced directive on file, and does anyone besides me know where it is? Have I done anything meaningful in the last year to build physical reserve rather than slowly lose it? The 5-question pre-surgery checklist. Before any surgical consultation, elective or otherwise, bring these 5 questions with you, written down if you need to be. What is my personal individual risk based on my age, my conditions, and my current function? Not the general average quoted for this procedure. Has my overall physical reserve been formally assessed, or only my anatomical problem? What are my realistic non-surgical alternatives, and what does the evidence actually say about them for someone like me specifically? What does recovery genuinely look like, measured in weeks and in function, not simply in survival? What happens if I wait or if I say no? And is there still a window to change my mind and proceed later if things change? Any surgeon practicing thoughtful, patient-centered medicine will welcome these 5 questions without hesitation. If one of them brushes past you impatiently for asking, that reaction is information too, and it's worth pursuing a second opinion before you commit to anything. None of what you just heard is about being afraid of surgery or refusing care that could genuinely save your life. And it's about understanding clearly and permanently that a surgical recommendation is the start of a conversation, not the end of one act, and that you are allowed and quietly encouraged to ask for the full picture before you ever sign anything. Your step for the next 30 days is simple. Pick one thing this week and actually commit to it. Have the advanced directive conversation with your family, even if it feels premature. Add a real protein source to every single meal. Book 10 minutes a day for basic strength work, nothing fancy required. None of these guarantee away every risk, so nothing honestly can, but each one shifts the odds quietly back in your favor, long before you ever need them to. If this gave you something you can genuinely use, subscribe. This is exactly what this channel exists to do. And if someone in your life is facing one of these 5 surgeries right now, send them this video before they sign anything at all. It might be the single most useful thing you do for them this month. I'll see you in the next one.